Okay, hello everyone. Thank you for joining us for our mathematical modeling webinar. My name is Inez Tamajong and I'm the program associate at UCHAPS. Before we get started, I'd like to just quickly review a few things. Our speakers are going to present their content and then answer questions from the participants. So we ask that you please hold any questions until the end of the presentation. Please remember to keep your microphones muted when you're not speaking and to minimize any outside distractions, particularly cell phones. Now I'd like to introduce our presenters for today's webinar. Today we have speaking Joanna Malone. She is a doctoral student in infectious disease epidemiology at Johns Hopkins Bloomberg School of Public Health. Her research focuses on HIV prevention and treatment efforts among racial and sexual minority groups, particularly surrounding PrEP use. Joanna is especially interested in how intersectional marginal identities affect one's HIV status. She has a background in social sciences, having received her BA in sociology from Harvard and a Master of Science in infectious disease epidemiology from Harvard T.H. Chan School of Public Health. She is currently involved with conducting her dissertation work with a study that aims to test a case management intervention to help participants achieve viral suppression. We also have Forrest Jones. He is a PhD student in infectious disease epidemiology at Johns Hopkins Bloomberg School of Public Health as well. Prior to joining Hopkins, he was an ASPPH CDC Alan Rosenfeld Global Epidemiology Fellow stationed at the CDC office in Dar es Salaam, Tanzania. He received his MPH in epidemiology of microbial diseases from Yale School of Public Health in 2015 and a BS in chemical biology from UC Berkeley in 2013. He is passionate about the combined use of dynamic models and field studies to inform public health interventions. Please welcome Joanna and Forrest.
Specifically with mathematical modeling of HIV. And so I'll just go over the general outline of what we're going to be talking about today, and as well as some terminology that we want to make sure everyone's clear on. And then Forrest is going to take it away. I'm going to come near at the end to specifically talk about HIV. So here are our names and the title of the presentation. The idea about why we do mathematical modeling, especially when it comes to infectious diseases. And then Forrest is going to go over a toy example of a commonly used mathematical model called an SIR model. And then later on, I'm going to talk about why modeling HIV is important and challenges that come with modeling HIV. And then I'm going to go over examples in the literature where we see mathematical modeling of HIV happening to address specific issues in HIV prevention and treatment. Some of you already might be familiar with these epi terms if you do epidemiology or research, but again, just to make sure everyone's on the same page. When we talk about incidents, we're talking about new cases that happen over people who are the total population that's at risk. So, not people who already have a certain disease, but, if you're looking over time, any new cases that happen over that period of time are incident cases over that period of time. And specifically, if you want to look at the rate of a certain disease, again, same idea as just looking at new cases, but over time, as opposed to prevalence, which speaks to the burden of disease at a specific point in time. And so again, if you were to go out and test for cases of HIV, of people who already have the disease out of your whole entire population, say Baltimore, where we are right now, then that would be the prevalence of HIV as it is today at that point in time. And I've already kind of talked about, again, how this relates into a rate with incidence of their events over time. So unless we have any confusion about that, we can talk about that later on at the end. If that was still unclear, I'm going to hand over the presentation for us, and he's going to go over, again, mathematical modeling in general, and then go over an example of a commonly used model in mathematical modeling.
Great, great. All right, hi everyone, this is Forrest speaking, and I'm really excited to talk to you all a bit about mathematical models today. I think it's amazing how far the field has advanced in the past few decades, and it's exciting to hear that your organizations are interested in learning more about it. So in infectious disease epidemiology, there are a lot of different questions we might want to know in terms of pathogen spread. And things that we might want to know is what pathogen is causing the disease? What are the risk factors that are causing infection? What treatment is most effective? And how many people are actually infected? And we have a lot of great tools for answering those questions. We can conduct a clinical trial to understand whether a treatment is effective. We can conduct surveillance to understand how many people are getting infected, and also do case control studies to look at risk factors. But there are limitations to many of these methods, and certain questions that you cannot answer. So things that you wouldn't be able to answer with these tools are: will a disease become endemic in a new population? How many cases will be reduced after you do an intervention? And can we eliminate a disease from an area? And this is really what mathematical models are great at. They can answer these questions through creating a hypothetical population and running simulations to ask these complex questions that can not really be answered in these field studies. So to get a little bit more specific, I want to talk about first what makes infectious diseases special. I mean, you've only really to be representative of a population of people becoming sick. So prevalence shows kind of the level of the balls in terms of what percentage or how many people are actually infected with the disease or have the disease. Incidence is the rate at which the balls are coming into the jar. And then the prevalence can also decrease based on whether people are dying or cured of or if they are cured of the disease. So this is a way to sum up all these epi terms in one succinct picture. What we think about what impacts incidence normally, we think about people's genes can impact their whether they get a disease, whether there's an environmental factor that might make them more likely to have a disease, or if there's a certain behavior that they do that might predispose them to having a certain disease. You might think of diseases that are caused by these might be diabetes, cancer, heart attack, cardiovascular disease. And this is a great model for thinking of those. But infectious disease, there's one thing that distinguishes them, and there's another thing that impacts incidence. And I would say that I would argue that this might be the most important slide of the session, so pay attention if you to this. And that is that prevalence also impacts the incidence of disease. How many people that are infected in the population will then impact how many people will get infected the next day. And this is what makes mathematical modeling necessary. This dynamic feedback that occurs from prevalence impacting incidence is really what makes infectious diseases special, and why mathematical models are necessary to answer those questions that I had on the previous slide. And just quickly, some additional terminology when talking about mathematical models. In case I mix them up, mathematical models, dynamic models, mechanistic models, these are all types of things that you might hear when in the field, talking to people that are in this field. Really, they're pretty much interchangeable, and it's not worth distinguishing. And mathematical models also can come in many different types of flavors. There are deterministic and stochastic models. Deterministic show really an average estimate for what you would expect in a simulation, whereas stochastic accounts for some random effects that can occur when transmission is occurring. And then compartmental versus agent-based further, there are other, then you'll maybe get an idea of what, you won't be intimidated when you see these terms later on. And then mathematical models are a bit different from statistical or probabilistic models, which some of you might be more familiar with. Those statistical and probabilistic models often assume that observations that you're fitting a model to are independent of one another, whereas mathematical models will ever hear about in terms of infectious disease. You should be familiar with this if you want to have an understanding of any mathematical model, I think. So quickly, before we talk about what the SIR model is, I just want to talk about what makes a good model. And the idea is that model that I want to get across to you all is that modeling, determining whether a model is good or not, is a bit of a subjective process. You have to weigh whether this model is representing the reality that is important to you, but also is it simple enough that it can actually be interpretable after the fact. And one of my favorite quotes from the famous statistician George E.P. Box is that all models are wrong and some are useful. And I think that's really important when thinking about any model that's presented to you, that this is not actually what is happening in the population, but this is based on our knowledge, the scientists' best interpretation of what they think is going on and what will happen if you put an intervention in place. Great. So for this, as soon as you are infected with the disease, then you're already able to start infecting other people. There's no kind of latent period before that. And then also after a while, after somebody has been infected for a little bit of time, they eventually will recover and that are immune to future infection. So you can see here these little stick figures here. The blue is going to represent S for susceptible. I is going to resemble, red is going to be for I, which is infected, and then green is for R, which is recovered. And also just to note that there isn't a vaccine or anything like this. You can only be in susceptible, infected, or recovered. So in this example, we're going to say disease X. We're going to look at an outbreak of disease X in a summer camp. And there's going to be 100 campers, and that on the very first day, on day 1, there are going to be 2 people that are infected on day 1. So there are going to be 2 people that are in the I compartment, 98 people that are susceptible that are in the S compartment, and 0 people that have recovered that are in the R compartment. And you can see this population of 100 campers on the right with 2 little red infected people. And another way to kind of show this, again, is that you have 98 people in the susceptible compartment, 2 people in the infected compartment, and 0 people in the recovered compartment. And you can only go Now, one thing I just want to note for this presentation is I'm trying to avoid using too many equations or too many Greek letters. So this here, I'm going to be using boxes to represent the number of individuals in each compartment. So blue here is going to represent the number of susceptibles. And you can see here that the number of susceptibles on day 2 is equal to the number of susceptibles on day 1 minus the number of new infections on day 1, okay? We're gonna get to how to calculate the number of new infections on day 1 later, but just there. And then lastly, we have the recovered compartment. The number of people that recovered on day 2 equals the number of recovered people on day 1 plus the number of new recoveries on day 1. So calculating the, we already have the green, red, and blue boxes on the right. We want to calculate the green, red, and blue boxes on the left, but we don't know what the yellow and purple boxes are yet. And that is our goal. And quickly, just a slight notation thing, if you wanted to calculate this for day t or day t minus 1, you would just replace 2 and 1 with day t and day t minus 1. And if you wanted to see the actual equations for this, you could write them out this way, where S is, uppercase S is susceptible, uppercase I is infected, R is recovered, and then lowercase I is number of newly infected people, and lowercase r is the different for measles, different for influenza. That is a biological component of the disease. And then to calculate the purple box, the number of new recovery T, we need to know also the number of people that are infected on day T, and also the rate of recovery. And that's, again, the biological part of the disease. So if we want to actually look at the equations to get these yellow and purple boxes, I've written this out here. Basically, that lowercase I, the number of new infections on day T, is the infectiousness times the number of people susceptible times the people that are infected. And then lowercase r is the number of recoveries. That's back at our mathematical equations for the SIR model. We are able to calculate everything on the right-hand side of the equation in order to calculate things on the left-hand side of the equation, which means that we can simulate every day. We can simulate days into the future how the outbreak will progress through the population. So let's go back to our example in disease X coming to a summer camp. We have day 1, we have 98 people who are susceptible, 2 people are infected, 0 people who are in the recovery compartment. And for this example, I'm going to assume an infectiousness of M and a recovery rate of Q. These are just 2 numbers that I chose that would be easy to show in this example, but you can modify those to many different things. And instead of showing a population of people, I'm going to show a graph on the right to give you a sense of how the number of people in each of these compartments change over time, where the blue dots are representing S, the orange dots are representing I, and the gray dots are representing R. So let's go one day to the future. Let's go a few days in the future. So days 1, 2, and 5 we have here on the left. We can see that the number of susceptibles decreased from 98 people down to 96 people on day 2. 3 people are now infected, and now there's one person who's recovered. And then if we fast forward even further to day 5, it goes even further down. The number of people who are susceptible is down to 83. We now have 9 people who are infected, and 8 people have recovered from the disease. And you can see on the right-hand side now a graph of the general trend of the susceptibles decreasing and the numbers of infected if you see on the right-hand side, you can see now how the number of susceptible people dropped and then plateaued. The number of people who were infected rose and then dropped. And then the number of people who were recovered rose and then plateaued. And this phenomenon has to do with the fact that the number of susceptibles has depleted in this population. Assumptions that we made in this model is that no one person, that everyone was the same age, they all had similar behavior, and they all had similar health status. They were all equally susceptible to the infectious disease. That's also most often not the case. One of the biggest assumptions, and the one that I want to try to focus on a little bit here, is this idea of random mixing. And this has to do with that equation I showed you, where the number of new infections is determined by the product of the number of susceptibles and the number of people infected. This equation really is saying that everybody who's susceptible is equally likely to come in contact with somebody, with every person who's infectious, and vice versa. But in reality, that's not the case. We exist generally in networks. People that live with you in your household might be more likely to catch the flu from you rather than your cousin on the other side of the world. In reality, we live in contact networks, and this model does not account for that right now. And there are other types of contact network models that do account for that. But this model, by being a compartmental model, does not go into dealing with contact networks. Also, another thing that I already touched on a little bit earlier is that transmission is a deterministic process. In this case, that we're basically modeling an average scenario. We could have also incorporated stochasticity if we wanted to see all the different types of scenarios that may have occurred for this outbreak. And then lastly, we also chose parameters for infectiousness and the recovery rate. So that these were parameters that I chose that were easy to use and easy to show in this example, but I'm just going to go through quickly some of the ways that you could modify the SIR model if you wanted to deal with some of those assumptions I mentioned. So if you wanted to add demographic changes, so for people being born or dying, you can have a rate of people being born into the S compartment, but then having a death rate for people that are susceptible, infected, or recovered. You can change those, so you can make those all equal, you can make them different based on your disease. You also, one thing I didn't show here is that you can show people aging into different age groups, and Joanna's going to touch on an example where that occurs, but you're able to show basically because different people have different chances. Or virus or pathogen has to multiply in your body to a point where you can start being infectious to others. So putting in an E compartment where where you've been infected and you will eventually transmit to people, but just not quite yet, accounts for that phenomenon. And then lastly, if you wanted to model interventions such as vaccination, this is an example of how you would add a vaccination, a type of vaccine that can provide permanent immunity to susceptible individuals. And now that people are susceptible, they can either eventually become infected or they can also become vaccinated. And once they become vaccinated in this situation, they remain vaccinated for life and not able to get the disease. I think that is it for me, so I'm going to
have and how those things can relate to mathematical modeling, what mathematical modeling the HIV is typically used for. So the main two things, questions that typically, at least right now, in terms of the big issues with HIV, that can occur are some of these, and these aren't all the questions, but just to prime your thinking. One would be, say, for instance, if you wanted to know if a certain percentage of a group at high risk for HIV, which a lot of you may know that young Black MSMs, or men who have sex with men, and transgender women, et cetera, fall into that group. So if you wanted to know, what percentage of this group, if they were taking PrEP, how many HIV cases would be avoided if this group were taking this and you might be a bit more familiar with this as well, and we're going to talk about this, is, if a certain percentage of people were tested, treated, and virally suppressed by the year 2020, how many HIV cases would be avoided, and what would this mean for the survival of those living with HIV? How many people would be living healthy with HIV if these people were tested, treated, and virally suppressed? And if that sounds familiar to you, you probably are familiar with the UNAIDS targets for 1999. That I just talked about, we're really thinking about, what are these interventions going to do for the populations that we're interested in, and depending on what goals that we have for that population. So I already mentioned PrEP and a little bit about treatment as prevention. And so it would take for, or how many cases could be avoided CDC, has come out recently with this whole U equals U, or this undetectable equals untransmittable. So now treatment is another prevention strategy that we should be thinking about in conjunction with things like PrEP, and test and treat and things like that, with treatment as prevention. And so people ask these questions when it comes to, modeling, if we had X percentage of people who are on HIV treated, and adherent to their ART, if that would prevent more cases of HIV as opposed to doing a PrEP intervention, or what would happen if you did both of these types of interventions together. I already mentioned 90-90-90 by 2020, but we're gonna go into specifically an example about the model that's used for this. So this isn't just like a kind of random figure that UNAIDS kind of came up with, but they used mathematical modeling to reach viral suppression by the year 2020. And again, these are the types of estimates that, the reason why there's certain goals that we have is because somebody did a model to where they could figure out that, okay, if we had these types of figures of 90% for this group and 90% of that group and et cetera, then we could reach this goal of preventing X number of cases of HIV by this time period. And so these are the types of the real world examples if you had a bar graph and you had, X number of people who are living with, HIV, but in terms of your work that you do on the day-to-day, but these issues are things that we've used a lot when it comes to mathematical modeling. So again, going back to the example that we already learned about, common use of random mixing, or that there's no network structure in the population that we're trying to model these interventions in, or this disease in. And clearly, when it comes to HIV, this isn't the case. You have to take into consideration when it comes to HIV or any type of STI, that there are sexual networks that you're working with. And so we have an example here. This isn't on HIV. I think this is specifically on syphilis. This has been an example used in the literature for this fictional, it's a real high school, but they have a fictional name, Jefferson High School. This shows the sexual network of the high school and the contact transmission that this particular STI, how that transmitted through the high school through these sexual networks. And you can't estimate, you wouldn't be able to accurately estimate how that disease spread if you use that SIR model that we talked about before, if you didn't take into the consideration this network that that applies to HIV and other STIs. The other thing that doesn't work when it comes to HIV a lot of the time is people are reaching optimal health, and that's considered quote unquote, recovered, or at least, of good health for that ARC compartment. Or more specifically, maybe people might use another goal like ART adherence, or at least, access to healthcare or something else. But the point being is that, these are some type of modifications that you kind of have to think about when you're modeling HIV. And so again, these are the two examples that I talked about before when it comes to PrEP versus treatment as prevention strategies. So again, these are things that of how this would kind of appear in the similar SIR model that we talked about, and things that you have to kind of think about when implementing these things in the models. So we already kind of talked about, say, if you had a vaccine in some type of intervention strategy for a certain infectious disease in a population. And so similar when it comes to PrEP, as we know, people are adherent to PrEP. They have a different chance of getting HIV than people who are not on PrEP. So you have to take that into consideration in the model. And so here we have this box of the P here, and that people, who are susceptible, if they start taking PrEP, they're now going to be in this lower compartment, and now they're going to have either, depending on how you want to, think about it, you can either kind of consider these people to be immune and not have them go into the infectious compartment, which we kind of have here. Or some people, if they want to capture the fact that, you know, people aren't as adherent all the time to PrEP, so they still have a chance of getting HIV, but they still, you know, you still have to pay attention to the fact they have a lower chance of getting HIV. You know, they might have an arrow pointing to this I compartment, but, you know, at a different, people are moving from this P compartment to the I compartment at a different rate than people from the susceptible compartment to the I compartment. And again, these arrows that are going in and out are just respecting the fact that people can go on and off treatment. The same thing with this T compartment. This is talking about a treatment as prevention strategy. So people who are already infected are then going to become treated. And then again, with what we know about HIV and being on treatment and adhering to treatment, that again, you can think of them as not being able to transmit the disease. So they're not contributing to the epidemic anymore if they're truly adherent. But again, if we wanted to incorporate the fact that not everyone adheres to medication all the time, they still might contribute to the epidemic. You know, you might have other arrows pointing into later compartments down the line. And so I just wanted to show that this is how typically, you know, it's a really simplistic example, but this is how you would kind of incorporate these types of strategies into a model. And again, we're going to go over an example where other characteristics like demographics and cost effectiveness of certain prevention strategies like PrEP versus treatment as prevention can be looked at and assessed when using mathematical models. So the next slide, we talked about the model that's used for the HIV care continuum, and I think it's something that a lot of us can relate to. So I wanted to make sure we had time to really focus on that example, and then I'm going to go over some other examples in the literature that we see when it comes to mathematical modeling. So Forrest is actually going to go over the spectrum model, and then we're going to go over some examples in the literature.
Great. So just a quick aside on the spectrum model. Joanna already introduced it very well earlier, that we have very little idea. HIV is, we don't actually know how many people are infected with HIV at any time. We don't know that really about any infectious disease, really. But how do you get an idea of that without doing large, comprehensive cross-sectional surveys of the whole population consistently? And so the spectrum model tries to get at this. And what is done is that the UNAIDS reference group basically puts together a model ahead of time before looking at any data, and every year updates it maybe a little bit, some years more than others, and then brings in these teams from people that are working in the Ministry of Health, working with agencies like CDC or WHO in country for different countries around the world to come bring data to get specific estimates. So if they do have cross-sectional national sera surveys, then they'll bring those. But what's more important as being brought consistently are program data on ART, as well as demographic, epidemiological, as well as clinical data like viral load, to give a sense of, okay, you may have this many people on treatment, but how many of them are actually having viral load copies below 1,000? And then I just also want to note is that this spectrum model is made for two different settings generally. That you have generalized epidemics, which have a prevalence of HIV greater than 1% in age groups between 15 and 49, as well as concentrated epidemics where the prevalence is lower than 1%. So generalized epidemics, they generally need information on routine data, routine testing for HIV. Generally, it's from antenatal clinics. Whereas concentrated epidemics, they require data on key populations and need to have idea of how large these key populations, such as men who have sex with men, sex workers, and injection drug users are, and what is the HIV prevalence in that group. And yeah, I'll hand it back over to Joanna.
Yep. So I just wanted to give we wanted to provide a more detailed explanation of, you know, we use this all the time when it comes to the HIV care continuum. This is just a bit more insight that mathematical modeling actually helps provide those baseline estimates that we based off of all of those other bars in that care continuum off of. And so I'm going to go over just 4 quick examples in the literature on how mathematical modeling is used as it relates to HIV. And I'm going to try to tie it back to the community and how you can use this in community organizing and community work. So I know a lot of you are currently involved in that. And I'm also, if we don't touch enough about that, we are definitely open to people asking questions again if you want to know, like, how is this relevant to my work on a day-to-day. So we'll definitely have time for that discussion. So this is an article that was published in The Lancet in 2009. And so the point of the article was to trying to see, what would universal voluntary HIV testing do when it comes to testing and, immediate treatment of ART for those who are infected. How would that strategy, be used to eliminate HIV transmission in the future? And so this is the model that they use for that paper. So obviously it's a lot more complicated than what we had been going over before. But I mean, you can see that there are a lot of similarities from what we were trying to get you to look at before. And so I'm going to try to explain kind of the modifications that, feeding off of what you already were seeing before, the SIR models or the SEIR models, and how, this is pretty much a similar take on all that, but, the people who are doing the study had to think about different here is, it doesn't encompass all ages in the population. So the researchers made a decision to only include people who are at least 15 years older because they were thinking about HIV and they're thinking about, okay, well, when are people starting to become more sexually active and thus more at risk of being infected? The BN, taking that into consideration, so Forrest alluded to this earlier, but this is the rate at which people are susceptible. So, N again is the number of people in the total population, and then this beta here is the rate at which people are becoming susceptible, quote unquote, to HIV. And again, that takes into the consideration that not everyone in the population is 15 years or older. So this is at pretty much the rate at which people are turning 15 and now are at risk, or so to speak, or susceptible to HIV. So that's what this parameter is speaking to. This ugly-looking parameter here is all the Greek letters and things like that. It's just a simple parameter that's just looking at the rate at which people are becoming susceptible into becoming infected. And then you see there are all these different compartments of infection, because this article actually is specifically looking at different CD4 count cutoffs for ART treatment. And so they were trying to compare people who had immediate treatment to ART versus people who were infected and had delayed treatment to ART based off of their CD4 level. And another thing to point out here when it comes to this, the figure here, so it's lambda S J over N, but like we said at the very beginning of the presentation, this J is actually taking into consideration the number of people who are already infected. So that is going to be really important in terms of the rate at which people are becoming infected, because it's going to depend on the number of people who are already infected. And so again, that's the key point, is that what makes infectious disease so special, because you do have to take into account the number of people who are already infected. So that the rate at which people are moving from S to I is at mercy of that. When it comes to this mu, this is the mortality rate. And so again, we talked about how not all of the models take that into account. Well, this one does, because the mu is taking into account that people are leaving the population and dying out, either from being susceptible, or if they die when they're infected, or at different parts of infection. The P is the rate at which people transition from the infected compartments. We don't have to get into the details of that, but again, these are showing different levels of infection. And the ART, again, is different time points at which they have ART use. And the sigma figure here is the rate at which people transition from the different ART use, levels of ART use. And then this figure here is, again, the rate at which people transition from being infected after use of ART. So people are kind of moving in and out of these different boxes, and they're taking note of that. So this is, again, we don't expect you to digest everything in this model, but this is just to show you that these are similarities of what we already saw before, and how people use different parameters to kind of estimate, the rate at which people are moving through these different compartments, the rate that the epidemic is flowing, and then, this D at the end is the number of deaths. So again, if you wanted to see, how many deaths, are, would this whole epidemic result into based off of these different types of treatment strategies, you could do that with this type of a model. So this article is from people at Emory. This was published in American Journal of Epidemiology actually this year. And so this is addressing gaps in HIV pre-exposure prophylaxis care, so PrEP use and reducing racial disparities in HIV incidence in the US. And basically what they found when they used this network-based mathematical model, so again, they had to take that into consideration because they're working with HIV and had to take into consideration sexual networks, that compared to not having any PrEP use in this population, that you potentially be able to decline the HIV incidence by 23% among Black MSM if we really, over the next 10 years, if we really had a service organizations are if people adhere to PrEP over a certain period of time, or if they do this or that, then we'll be able to reach all these great goals. But that means nothing if people in the community aren't able to do the job they need to do and actually reach the population that needs these types of services, and to actually they were pretty much comparing different strategies with different regions across the globe on, to do 90-90-90 versus 95-95-95 for an HIV vaccine. And this kind of is just, again, is showing you how people use models to kind of compare what would be the outcomes based off of these different types of interventions. And as you can see, the strategy that compares the 95-95-95 in the vaccine has the best outcome in decreasing the overall cumulative incidence, or again what we the cost effectiveness percent of cases would be prevented over the next 5 years in New York State or New York City, but this actually results into an incremental cost of over $31,000 per quality adjusted life years saved. And so people definitely take this into consideration when they do model certain outcomes of different strategies with mathematical modeling and compare how much one disease or one intervention would cost versus another type of intervention. So that's pretty much our presentation. So we're here and open for any questions that you had coming up, and we're happy to talk more about what was discussed over the presentation.
For those of you that have questions, please feel free to enter them in the chat box now. Okay, we have one question from Haley Gilmore that says, what software do you work in? I have used Berkeley, Madonna, and R for modeling, but curious what else there is.
So that's a great question, and I think it's that's great that you've been using Berkeley Madonna and R. I've heard a lot of people use Berkeley Madonna, but more so and more so people are switching over to R often. I've also worked in Mathematica and MATLAB. Those are also sometimes languages that are used for it, but it seems that there are largely a lot of people that are using R these days.
I think Python
And
might be used as well. Right?
yeah, yeah, and Python too sometimes. So it might be a bit more challenging in a language like SAS or Stata, for example.
We have another question regarding whether or not there'll be more webinars breaking down modeling for HIV and what to use, and I can take that and say if there's interest, please contact UCHAPS and send us your questions so that we can think about how we want to focus the webinars and what information you all would like us to cover. Another question, I'm interested in running these models with data from our jurisdiction. Do you have SAS code or R for these models?
And then all the other examples that were used in the articles are, I mean, they're already published examples, so we don't have the code for those. But if that answers your question.
Yeah. Sure. I think like whether you need a network-based model versus a compartmental model, for instance, and I think a lot of these papers should be able to provide some of their code online that could be helpful with this. And again, I probably would hesitate with using SAS for a type of model like this. R probably would provide the flexibility needed for it. Great. Here we have a question. What resources would you recommend to develop modeling skills? So there are a few books, and maybe we can write those up, and I can, while the next question comes in, I can look up the exact titles, but that I could recommend. The most common, I think probably the most well-known book is Infectious Disease in Humans by Anderson and May. That's kind of the original infectious disease modeling book. There's also another one by Emily Vinicky, but I'm gonna look this up right now so I can get the exact spelling. But I'd say there are a few books. There are lots of now seminars that are going on for this. I know that Imperial College, as well as London School of Tropical Hygiene and Medicine probably does one. I think at the Epidemics conference, they probably have trainings for this as well. But honestly, like the majority of mathematical modeling has been done by universities in the past, and so often it's been through taking courses at a school in a graduate program has been, I think, the majority of how people have learned it in the past. But the people that have come from engineering have picked it up pretty quickly as well. So yeah, look at those.
Okay, you all can continue sharing your questions in the chat box if you have any more, but I'd also like to remind you that we will be having a Facebook Live seminar at 3 p.m. with Matthew Rose from NMAC on mathematical modeling to continue this discussion. And I would also like for you all to take a moment to complete a survey on SurveyMonkey about this presentation so we can get your feedback. I've included the link here in the chat box, so please take a moment and fill that out. if that's it for questions, then I think we can wrap it up here. I'd like to thank our presenters today, Joanna and Forrest, for their wonderful presentation and the information that they've shared. Thank you so much. For more information, I'm sure we'll be sharing the presentation in the